So, hello everyone, am I live? Am I live? Please confirm once. Am I live? Those who are watching. Okay, so today we'll discuss a very important chunk of hematology, that is leukemias. So, every time you can expect this type of questions. Once just go through the questions. Just once go through the questions. Okay. Am I live? Once let me confirm, then I'll start. Am I live, students? Okay, yes, I'm live. 1 minute, I've already done. Why it's not showing there? Just a minute, I'm coming live. Okay, so I'm live. It's confirmed. Fine. I'm live. I'm absolutely live. Okay, so let's go for it. Okay, I think everything is going fine. So now let's start without any further ado. So see here, define and classify leukemia. So you have to talk about leukemia, you have to define it, and you have to classify it. You have to describe the laboratory diagnosis of acute myeloid leukemia, CML. Okay, AML, acute. Okay, then classify leukemias, describe peripheral blood smear, bone marrow of chronic myeloid leukemia. Talk about myelodysplastic syndrome, leukemoid reaction, etiology of leukemia, FAB, WHO classification, acute leukemia, FAB, that is French, American, British classification, cytochemistry, myeloid leukemia, and all these stuff. Let's quickly go through. So, what is a leukemia? Let's first know the definition. I want you to learn each and everything right now. Okay, don't delay it. After lecture, you will learn and all. Learn now itself. Okay. Now itself you have to learn. Okay, so leukemias are neoplastic proliferation. Leukemias are neoplastic proliferations of white cell precursors characterized by diffuse replacement of normal bone marrow of leukemic cells with variable accumulation of leukemic cell in the peripheral blood. Sometimes there is infiltration of organs such as the liver, spleen, lymph nodes, meninges, gonads by leukemic cells. Okay, so leukemia are neoplastic proliferations of white cells, the precursors. Okay, it is characterized by diffused replacement of normal bone marrow by leukemic cells. Okay, now let's talk about classification. Classification, you can see depending on natural history of disease, acute, you can have acute. If untreated, they cause death usually within weeks to months. It is very acute and very severe. In chronic you can see if untreated they cause death after several years, depending on cell type, predominantly myeloid leukemias and lymphoid leukemias. So you can have four types: two myeloid and two lymphoid. One is acute myeloid, another is chronic myeloid. Okay, one is acute lymphoid, other is chronic lymphoid. I hope you understood. So you have leukemias, two types of leukemias you have. Where is my pen? Okay, I hope it will help us. Leukemia. So you have two types of leukemias. One is acute, it's acute, another is chronic. It's not acute, it's chronic. So you have two types. Okay, in acute you have how many types? Myeloid and lymphoid. You have myeloid and lymphoid. And in chronic also you have myeloid and lymphoid. Okay, myeloid and lymphoid. So you have two types of leukemias, acute and chronic. Acute, you have acute myeloid leukemia called as AML, and acute lymphoid leukemia, ALL. In chronic you have a chronic myeloid leukemia and chronic lymphoid leukemia, CLL. Okay, so this classification with flowchart is very important. Let's talk about etiology, about the genetic factors. So if you see, these leukemias are common in the people those have already mutations like Down syndromes, like Klinefelter syndrome, like Turner syndrome, DNA repair defects, repair defects, Fanconi anemia, Bloom syndrome, ataxia, telangiectasia. So they are DNA defects. Congenital defects like the Down syndrome, Klinefelter syndrome, and Turner syndrome. In these people, the chances of having leukemia is more because of the genetic disorder. In DNA repair, Fanconi anemia, Bloom syndrome, and ataxia telangiectasia. Talking about ionizing radiation, let's quickly talk about the ionizing radiations. The ionizing radiations, you have atomic bomb exposure, nuclear bomb power exposure, and pen is not working. It's really waste. Okay, medical radiation. So ionizing radiation is atomic bomb exposure, nuclear power exposure, and medical radiations. Like if some people go for the radiotherapy, and also some anti-cancer treatments like alkylating agents, they can also cause the uh, leukemias. Topoisomerase 2 inhibitors, and viruses like the retroviruses, RNA viruses like HTLV1, and immunodeficiency states. So you have four types in etiology. You can write about genetic. In genetic you can divide into congenital and the DNA repair defects. In congenital you can talk about the Down syndrome. What is Down syndrome? Trisomy of 21, chromosome 21. Klinefelter syndrome, and you can talk about Turner syndrome. In DNA repair defects, you can talk about Fanconi anemia, and telangiectasia, telangiectasia. And other, you can talk about ionizing radiations. In ionizing radiations you can talk about the atomic bombs, nuclear power exposure. You can talk about medical radiations. In chemotherapy you can talk about alkylating agents, topoisomerase 2 inhibitor, retrovirus infections, HTLV1, not all retrovirus infections, immunodeficiency status, okay, like organ transplant or AIDS, like that. Okay, talking about first topic, that is AML. AML is nothing but acute myeloid leukemia. So it is a clonal expansion of myeloid blast in bone marrow, blood, and other tissues. Minimum is 20% of blast should be there in both peripheral smear and the bone marrow for diagnosis of AML. For diagnosis of AML, it is a clonal expansion of myeloid blast. It is a clonal expansion of the myeloid blast. It is a clonal expansion of the myeloid blast. It is a clonal expansion of the myeloid blast in bone marrow, blood, and other tissues. Minimum of 20% blast should be there in both, either in the peripheral smear or in the bone marrow for diagnosis of AML. At least minimum 20% blast should be there. So it is a clonal expansion of which series? Myeloid series. Okay, so it should be either in the peripheral smear, or or either in the bone marrow. WHO classification. WHO classification. One second. Okay, so let's see this. So WHO classification we have, and we have FAB classification. FAB classification is nothing but the French, American, and British classification. If you see in French, American, British classification, we will find that M naught is there, na? That is minimally differentiated, or you can say undifferentiated. Undifferentiated leukemia, okay, myeloid leukemia, undifferentiated. This is myeloperoxidase negative, myeloperoxidase negative, and here there are no OR rods. OR rods are absent. OR rods are absent in FAB, in M naught. Okay, in M1, AML without maturation, there is no maturation. Here there was no differentiation. Here there was no maturation. In second one with maturation, here promyelocytic, here myelocytic, myelomonocytic, here monocytic, erythroid, and megakaryoblast. Megakaryoblast nothing but platelet related. Erythroid means RBC related, and these are myeloid related. Okay, so if you see M naught is undifferentiated or minimally differentiated. These are myeloperoxidase negative. These are myeloperoxidase negative. There are no OR rods. OR rods are absent. AML without maturation, AML with maturation, promyelocytic leukemia, myelomonocytic leukemia, monocytic leukemia, erythroid leukemia, megakaryocytic leukemia. So here if you see minimally differentiated AML, minimally differentiated M naught, these are myeloperoxidase negative, or rods are absent. AML without maturation, AML with maturation. Here promyelocytic. This pro is very pro. It has something called as fudge bodies. I'll tell about this. So they have OR rods. They have OR rods, and these OR rods are present as crisscross manner. These are present as the crisscross manner. These are present as the crisscross manner. Okay, these are present as the crisscross manner. And in M3, that is AML, acute myeloid leukemia 3, they have if they get damaged, what will happen? They will release clotting factors, and which can cause intravascular coagulation, disseminated intravascular coagulation, that is called DIC. And they also have thrombocytopenia, so bleeding may occur, and patient may also develop disseminated intravascular coagulation. And acute myelocytic leukemia and acute monocytic leukemia, these two can cause gingival hypertrophy, and acute erythroid leukemia and acute megakaryoblast leukemia. Let's talk about the morphology. So they are large in size. The myeloid, acute myeloid, are large in size, almost equal to the size of the monocyte. The size is equal to the size of the monocyte. Nucleus is also large with delicate chromatin. Nucleus is also large with delicate chromatin. Nucleus is also large with the delicate chromatin. So nucleus is also large with a delicate chromatin. Chromatin is delicate, and 2 to 4 nuclei are there. The nucleus is large, the size is equal to that of the monocyte. The cytoplasm is abundant here. It is basophilic. It contains plenty of granules. It contains plenty of granules. The cytoplasm is abundant. These are basophilic. All rods are the distinctive features. What are the distinctive features here? What are the distinctive features? OR rod. OR rod is the distinctive feature. So OR rod is the distinctive feature. So these OR rods are red stained rod-like structure seen within the cytoplasm. These are present within the cytoplasm. These are red stained rod-like. Okay, that's what they call OR rod. Now talking about clinical features. So this is due to marrow depression. So how will be the symptoms like aplastic anemia? So but here there will be severe anemia, but leukopenia is more. Leukopenia means repeated infections. Uh, Not actually leukopenia. We can't use the term leukopenia here because uh, the patient will have the WBC count raised. But here all blasts are present. Here all blasts are present. Mature ones are absent. So that's why repeated infections are there. neutrophils count is less, the lymphocytes count is less, blast count is more. Okay, so that's why they have repeated infections. The common bacterial fungal infections are threatened in these patients. Okay, thrombocytopenia, they have purpura. Okay, rashes. Okay, due to marrow expansion and infiltration of subperiosteum, bone pain and sternal tenderness is there due to marrow expansion. Like in the sternum, if you see a bone marrow sternum, it will expand, and infiltration of subperitoneum and bone marrow and sternal tenderness can be seen. Due to organ infiltration of myeloblast, gum hypertrophy is there. Mostly M4 and M5 are responsible for organ infiltration, gum hypertrophy, lymph adenopathy, and hepatosplenomegaly. Hepato means liver and spleen. Both are enlarged. Okay, let's talk about investigations. What investigations you can go for? Go for the peripheral blood smear. RBCs, if you look at the RBCs, you will find they are normal, normal in size, normal in color, normocytic, normochromic, but here you will see nucleated RBCs also. Here there is a possibility that immature RBCs can also come in the peripheral smear. Variable anisocytosis and poikilocytosis can be seen. So here you can see the anisocytosis and poikilocytosis of RBCs. If you see about WBC, the leukocyte count is increased to more than 1 lakh per mmq. Sometimes may be reduced also, but mostly increased because of hepato and splenomegaly. It can be reduced, but mostly it is increased. More than 20% of cells are myeloblast. Here, more than 20% cells are the myeloblast. Platelets count is usually reduced. The platelet count is usually reduced. So here, if you see, one problem will be there is the leukocyte count is increased, but all are blast only, and here more than 20% of myeloblast. You can see the count is usually reduced. The platelet count is usually reduced. Hypogammaglobulinemia and Jane forms, you can see. Talking about the Cheney diagram, this is very important. If you see, these are the myeloblast. These are the myeloblast, and if you see, these are normocytic, normochromic RBC with center one-third pallor. Okay, the central one-third pallor is called normochromic, central one-third pallor. Okay, and if you see this are different stages of the RBC. These are your these are WBCs. These are neutrophils. These are something looking like M, so they can be myelocyte, and these are normal lymphocyte or lymphocyte. So different cells you can see here. Okay, so the bone marrow picture is very important, but one very important thing you will notice here, these are the ore rods. The pink color thing is the ore rods. Okay, and the cytoplasm, not in the nucleus. So bone marrow examination, the bone marrow is hypercellular, producing, dividing a lot and producing so many blasts. More than 20% of non-erythroid nucleated cells are myeloblast. Decreased number of erythroid precursors and megakaryocytes, because all are what? All are going towards the granulocytes. Talking about cytochemical stains is very important. Uh, if you go for myeloperoxidase, they stain your ore rods. Okay, so M0 ore rods are absent. So other than M0, M1, M2, M3, M4, M6 can show are myeloperoxidase positive. Sudan black is in M1, M4, same. Okay, chloroacetate estrase is only seen in M3 and M4. Non-specific estrase in M4, M5. Pass block positivity is seen in M6 and ALL, not in AML. In AML, you can only see in M6 one. Platelet peroxidase in the M7 because it is megakaryocytic associated. Let's talk about immunophenotyping. Immunophenotypic for the AML is CD13 and 33, and CD 16, 14, and 71 for M4 and M5, and for AML is M74142 and CD10 ALL. Okay, talking about chromosome analysis to detect recurrent cytological abnormalities, cytogenetic abnormalities such as for chromosome analysis, you can go for T2821 inversion of 16 and T5 translocation of 15 and 17. So you have two translocations, 8 and 21, 15 and 17, and one inversion, that is 16. So I hope this is clear. So this is about AML. This is about the AML. So in acute myeloid leukemia, let me summarize. So what is the definition of acute myeloid leukemia? AML is nothing but the neoplasm of hematopoietic progenitors characterized by proliferation resulting in accumulation of immature myeloblast in the marrow. So here there is a accumulation of immature myeloblast in the marrow. It is a neoplasm of progenitors, hematopoietic progenitors, hematopoietic stem cells progenitors characterized by proliferation, excessive proliferation, resulting in accumulation of precursor myeloblast in the bone marrow or in the peripheral sphere. Classification of acute, talking about the classification. In classification, you can see, so in classification you have WHO classification, and another classification which is very important is the your FAB classification, that is called British French American British classification, that is FAB classification. So this is very important. So in WHO you can see it is divided into many types. In WHO classification of acute myeloid leukemia, you have acute myeloid leukemia with recurrent genetic abnormalities, acute myeloid leukemia with MDS related gene changes, and therapy related myeloid neoplasm and AML not otherwise specified. But if you want the latest classification, this is the latest classification, easy to memorize when compared to other tables. So AML with recurrent genetic abnormalities, you can see that there is a translocation 821 inversion 16 and acute promyelocytic leukemia with translocation of 15 and 17. This is the AML with recurrent genetic abnormalities. In the AML with 821, you can have rungs 1 and rungs 1 T1, rungs 1 T1. Okay, rungs 1 T1, it is associated with translocation of 8 and 21. Translocation of 8 and 21 is associated with the rungs 1 and rungs 1 T1, and AML with inversion 16 is related with the Okay, so let's talk about this recurrent cytogenetic abnormalities. Recurrent cyto Okay, so if you see here, new WHO classification, according to new WHO classification, you are divided based on the recurrent genetic cytogenetic abnormalities, multilineage dysplasia, okay, therapy related AML, and not otherwise specified category. Let's talk about recurrent genetic cytogenetic abnormalities. Most important is these three: AML with the AML with the T821 translocation, 1517 translocation, and inversion 16. This takes place in this takes place in 22 chromosome Q arm. Okay, this is rungs 1 and rungs 1T1. Okay, and inversion 16 is associated with core CBFB MYH11. Okay, okay, so remember these three are the most important: AML with recurrent cytogenetic abnormalities, okay, fine. So here if you see AML with recurrent cytogenetic abnormalities, you have to remember two translocation and one inversion. Two translocations are 821 and 1517. only टू का डिफरेंस है ना, 1517 एंड इन्वर्जन 16. बीच में क्या आता है 16, तो 16 क्या हुआ, इन्वर्जन हो गया. So if you see acute promyelocytic leukemia, in that you have 1517 translocation. In 1517 translocation you have the promyelocytic leukemia rara. Okay, here 821 you have rungs 1 and rungs 1T1, and inversion 16 you have CBFBMYH11 gene. Okay, so these are the things about recurrent cytogenetic abnormalities. Talking about therapy related, as you know, alkylating agent and topoisomerase 2 inhibitor. Topoisomerase 2 and alkylating agents, they interfere with the DNA and all. So AML not otherwise specified is minimally differentiated, without maturation, with maturation, acute myelomonocytic leukemia, acute monocytic leukemia, acute erythroid leukemia, megakaryoblasttic, acute basophilic, and myeloid sarcoma. So these are the not otherwise specified. Not otherwise specified. Okay, not otherwise specified. Not otherwise specified is this AML minimally differentiated, without maturation, with maturation, myelomonocytic, monoblastic or monocytic, erythroid, megakaryocytic, myeloid sarcoma, and acute basophilic leukemia. Acute basophilic leukemia. Here you have AML with multilineage dysplasia, or you can say AML with MDS related changes. FAB classification: undifferentiated means minimally differentiated, without maturation, with maturation, promyelocytic, myelomonocytic, monocytic, erythroid, and megakaryocytic. This M3 is not there in this WHO classification. This is separately in recurrent with translocations associated with 15 and 17. And here we have the in 15 and 17 we have one gene, that is PML, promyelocytic rara retinoic acid associated. Okay, Morphology, if you see, these are small in size and large in size. So large in size, almost equal to the size of the monocyte. Nucleus is large with delicate chromatin, 2 to 4 nuclei are there. Cytoplasm is very abundant, basophilic. They consist of orods. Orods are distinctive red stained rods seen within the cytoplasm. Clinical features: anemia, bone marrow depression like features like anemia, repeated infection, thrombocytopenia. Due to bone marrow expansion, infiltration of a subperiosteum, you have bone pain and the sternal tenderness in the sternum tenderness because hematopoiesis in the adulthood is shifted to the sternum, so they have the pain. Okay, bone pain, sternal. Okay, pain. Okay, due to organ infiltration of myeloblast, gum hypertrophy, lymphadenopathy, and hepatomegaly is there. Hepatomegaly is there. Hepatomegaly is there. Hepato means liver and spleen megaly. Uh, Enlargement. Investigation, if you go for peripheral blood smear, you can see the normocytic RBCs. No problem. Sometimes you can see the nucleated RBCs in the peripheral blood smear and a nice variable anisocytosis and phagocytosis. Talking about WBCs, leukocyte count is increased to more than 1 lakh per cube, okay, cubic mm, and more than 20% of cells are the myeloblast. And here count is reduced and they are hypogranular and giant forms. If you see the peripheral picture, you will see myeloblast with the normocytic normochromic RBCs, normocytic normochromic RBCs with the orods, with the presence of the orods, and these myeloblasts are generally larger. These are larger. Okay, these are large. Okay, I hope this much is crystal clear. Now let's talk about the this bone marrow examination. So marrow is hypercellular and more than 20% of non-erythroid nucleated cells are myeloblast, and decreased number of nucleated, they are nucleated myeloblast, decreased number of erythroid precursors and megakaryocytes you can see, and cytochemical stains you can see the cytogenetics you can see that in cytochemical stains you can see that these are MPO positive except the M0 is not positive, remaining all are positive. Okay, and talking about the um, so in bone marrow, you will see the hypercellular stage. Hypercellular lot, it is dividing a lot. Erythropoiesis is suppressed. In myelopoiesis, suppression of myeloid maturation is suppressed, and myeloblast constitute more than 20% of marrow cells. And megakaryocytes is, poiesis is also generally reduced. Okay. Immunophenotyping diagnosis of AML is confirmed by using the stains for myeloid specific antigens. Okay, I hope this much is clear. So move on to next, but before that I want to give the summary of this topic what we studied. So once again, leukemias are the malignant disease of bone marrow. These are malignant disease of the bone marrow stem cells, bone marrow stem cells, okay, stem cells, hematopoietic stem cells, malignant disease. They arise from bone marrow and spreads. Okay, according to FAB criteria, there should be at least more than 30% of the blast count. But according to WHO, it should be more than 20% of the blast count. Okay, minimum blast cells in the bone marrow should be 20%, more than 20%. But for the FAB, it should be 30% in the bone marrow. Okay, it is important to differentiate between the lymphoblast and myeloblast because of difference in the treatment and prognosis. So differentiating malignant pre-B and pre-T lymphoblast and morphology is difficult, requires immunophenotyping for subclassification of ALL. TALL has worse prognosis compared to BLS. Symptoms in acute leukemia is due to bone marrow infiltration of blast. Bone marrow failure is anemia, neutropenia, and thrombocytopenia. ALL is So I'm telling about the ALL. Okay, these are the key features about the ALL. Then again, I'll explain what points I just uttered now. Okay. So ALL is the most common leukemia in children and is usually associated with lymphadenopathy. Lymphadenopathy is swelling in the lymph nodes. Okay. Subleukemic leukemia total WBC count should be less. So then 4 lakhs, 4 into 10 to the power 9 per lakh, and peripheral blood shows very few blasts. Leukemic leukemia means total white cell count is low, that is less than 0.10 to the power 9 per lakhs per liter, with no blast in the peripheral blood. If there is leukemic leukemia means there is a no blast in the peripheral blood. Both in subleukemic and leukemic leukemia, bone marrow contains more than 20%. Bone marrow 20%, but in leukemic leukemia and peripheral blood smear you cannot find anything. So it is leukemic leukemia. Leukemic leukemia. The screen is not working. Pen is not working. Okay. So lymphoblast should be differentiated from the myeloblast. How you can differentiate, ma? How can you differentiate lymphoblast from the myeloblast? How can you differentiate? How can you differentiate a lymphoblast from a myeloblast? See, if you talk about the diagram part, the in myeloblast you will see the ALL, and myeloblast you will see the OR rods. In myeloblast you will see the OR rods. In lymphoblast you will see the big nucleus. That's it. Okay, scanty cytoplasm. Scanty cytoplasm. In myeloblast you will see that MPO myeloperoxidase positive is there, and in the lymphoblast you will see the PAS positive. PAS positive is for the periodic acid skiff. Okay, with block positivity you will see some block positivity. The myeloblast stained positively with Sudan black. Okay, both are stained, but myeloblast are stained positive. Okay, if you talk about the lymphoblast cytoplasm shows block positivity with the PAS stain, periodic acid skiff stain. Distinction between precursor B cell and T cell requires lineage specific markers, and presence of Philadelphia chromosome in ALL prognosis unfavorable. AML synonyms acute myeloid leukemia. AML का क्या है? Acute myeloid leukemia and acute myeloblastic leukemia, or acute myelocytic leukemia. AML can occur at any age, but it usually occurs between the age of 15 to 60 years. 15 to 60 years means more in the old age, right? It can occur in the adulthood also, but not in the childhood. AML do not occur in the childhood. ALL occur in the childhood. ALL is more common childhood cancer, but AML is a aged one. Okay, symptoms in acute leukemia are due to anemia, neutropenia, thrombocytopenia. These things you can observe. These are the symptoms like failure of the bone marrow. So acute promyelocytic leukemia, that is AML3 M3, may be associated with widespread bleeding due to the formation of DIC, disseminated intravascular clots, or rod in the cytoplasm or myeloblast seen in AML, not in CML. So in AML only you can see the OR rods, and these OR rods are stained with the MPO, myeloperoxidase positive, and these are Sudan black positive also. Stained positive with myeloperoxidase and Sudan black B. AML prognosis: fulminant course and has worse prognosis than ALL. It has worse prognosis. AML has worse prognosis. It's very bad guy. Cytogenic markers are major determinants of prognosis. Cytogenetic markers you have to take. Biophenotypic acute leukemia is acute leukemia with a single blast cell population showing markers of two different lineages. Bilineal acute leukemia is acute leukemia with two different blast cell population. Biphenotypic leukemia is acute leukemia with a single blast cell population showing markers of two different lineages. Okay, and myeloid sarcoma, nothing but extramedullary myeloid tumor, granulocytic sarcoma or chloroma. Chloroma is nothing but myeloid sarcoma. Myeloid sarcoma is frequently seen in skin, lymph node, GI tract, bones, soft tissues, and testes. So this was the summary I gave. Just now, let's quickly discuss about ALL. ALL is commonly called as childhood cancer. It occurs in the childhood. Okay, this is the most common childhood cancer. So it is a malignant monoclonal proliferation of lymphoblasts. So here monoclonal proliferation is according to WHO classification. You have two types: precursor B and precursor T. So you have some markers for precursor B. For precursor B, you have CD19, HLA-DR, CD79, 10, and 22. Precursor T, you have 1, 2, 3, 4, 5, 7, single digit. Okay, 1, 2, 3, 4, 5, 7. T cell are single digit, but B cell are 19, 10, and 22. Let's talk about FAB classification. So you have three: ALL 1, 2, 3. Okay, in ALL1 is the childhood one. The cell size is small, small bachcha na, small. So regular may have cleft, nuclear shape may have the cleft in it, and nuclear fine or clump. Okay, nuclear material, nuclear chromatins fine or clump. Nucleoli is not seen, cytoplasm is scanty, and there are no vacuoles. Okay, there are no vacuoles in LL1. In LL2, LL2 is large and it occurs in adulthood. So large means adulthood. They have regular or may have cleft in the nucleus. The chromatin is fine, it is large and prominent nucleoli, abundant without vacuoles. Here's also no vacuole. But here in ALL3 it's large, it is also called Burkitt lymphoma, and is regular oval nucleus, as fine chromatin, large and prominent nuclei, but with plenty of vacuoles in the cytoplasm. So if you see ALL3, there are plenty of vacuoles in the cytoplasm. In ALL1, there are no vacuoles. You can see fine chromatin. Here you can see the chromatin. Here ALL2 fine chromatin. Okay, only difference is this in ALL2 and 3 is there is no vacuole in the cytoplasm. Clinical features: in addition to features of AML, pancytopenia, bone pain, and organ infiltration. So in AML, you can see pancytopenia, bone pain, and organ infiltration. Okay, serious manifestations due to meningeal spread can spread to meninges and cause headache, vomiting, papilloedema, testicular swelling due to infiltration can spread to testes also. So these the spreading one is the T cell ALL. Okay, T cell ALL, which is having bad prognosis. Investigations, so it is peripheral smear. You can see pancytopenia. Penia means reduced, so everything is reduced. RBC, WBC. In WBC, lymphoblasts are raised. But if you see the mature one, these are decreased. That's why there's repeated infections and all. Okay, bone marrow examination, lymphoblasts comprise more than 20% of cells. Cytochemistry, pass positive, it is pass positive. Chromosomal analysis, you can do CSF analysis to know the CNS involvement and meninges are involved or not. And, okay, so this was about the ALL, the lymphoblastic leukemia. You have two types: one is B lymphocyte and another is T precursor T lymphoblast. So this is nicely given in Robbins. If you study something from Robbins, you will fall in love with it. So this topic is very nicely given. Robbins, I don't think in other book is given that much nicely. So if you talk about, it's very detailed given. Uh, if you talk about pre-B cells, in pre-B cells you can find 10, 19, and 20, 22 like that. But for T cell, pre-T cell, precursor T cell tumors, you can find CD 1, 2, 3, 5, 7, 8. And Robinson is given 8. Okay, CD 8. So these are there. So this was about the T cells and B cell. So B cell is seen in children and T cell is seen in adults. Okay, and FAB classification L1 childhood, L2 in cell size is small in bacha. Okay, childhood, and regular may have cleft, and here fine or clumped, and here nuclei not seen. Scanty cytoplasm with no vacuoles. Okay, vacuoles are not there. So you can see clumped chromatin here, clumped clumped chromatin here. Here you can see the fine chromatin, here also fine chromatin. But in the vacuoles you can see the cytoplasm. You can draw this beautiful diagram. The organ manifestations is the same. The patient is having all the features of the pancytopenia, bone pain, organ infiltration is there. Organ infiltration is involved in T cell ALL, T cell ALL, testes, meninges, spleen, liver, um, all these are involved. Okay, central nervous system expressed to meninges also. One more important thing I want to ask, which is very much important, is the differentiation. So make a table. Make a table here. So make a table here. So in table, write down everyone. In table, good prognosis and bad prognosis. So first let's write the bad prognosis. Bad. Then write the good prognosis. Okay, let me write the good prognosis with a different color. Okay, I'll use a different color. For bad prognosis, you will see that for bad prognosis, you will see that the age should be less than 2 years. The patient's age should be less than 2 years. The patient is a baby, it's an infant. The age is less than the age is less than 2 years. Okay, the age is less than 2 years. The age is less than 2 years. Good prognosis, you will see the age is between the adults. It's between the 2 to 10 years, not adult. 2 to 10 years. The age should be between 2 to 10 years for the good prognosis. Okay, for good prognosis, what chromosomes you will see? You will see the cell count is low. The white blood cell count is low, and there will be hyperploidy, hyperdiploidy, hyperdiploidy, hyperdiploidy. You will see here trisomy of chromosomes. What are the chromosomes? 4, 7, 10. And you will also see the trisomy of translocation, presence of 1221 translocation. 1221 translocation. So this is about the good prognosis. Let's talk about the bad prognosis. The age is less than 2 years. Okay, the translocations, you see high blood count, that is greater than 1 lakh, greater than 1 lakh, 1 lakh WBC count. Okay, and you will see the MLL gene involvement, you will see the Philadelphia chromosome involvement 922, and its weight is 190 kilodalton. Okay, 190 kilodalton, and this 190 kilodalton is stronger than the CML wala Philadelphia. Okay, so that's why here poor prognosis. Here the prognosis is very bad. So this is peripheral blast count will be this much. Okay, so these are the important thing. Pakka you will get question from your PG, INISET, every FNG, any exam you will get the question for the good prognosis and the bad prognosis. Bad prognosis of, we are talking about AML. Okay, we are talking about the AML. We're talking about AML. Don't forget that. We're talking about ALL, acute lymphocytic leukemia. ALL. So ALL, you will find two types: bad prognosis and good prognosis. In bad prognosis, you will find that in bad prognosis, you will find the age of the patient will be less than 2 years. In good prognosis, 2 to 10 years. The peripheral blast count will be more than 1 lakh. Here it will be low. In bad prognosis, MLL gene is present. At Philadelphia chromosome is present of 190 kilodalton, which is more active than the CML wala Philadelphia. Here you will see hyperploidy. Here you, in bad prognosis, you will see hypoploidy, hypoploidy, hypodiploidy, hypodiploidy, hypodiploidy. But in hyperploidy, 4, 7, 10 trisomy and trisomy 12 and 21. So if you add 1 plus 2, 3, 2 plus 1, 3, 3. Here trisomy, hyperdiploidy. Diploidy means 2, hyper means more than 2, means 3. The age will be also more than 3, means 3. So 3 rule you have to remember for good, okay? So this is the important point. After this discussion, now let's move on to CML, that is chronic myeloid leukemia. Chronic myeloid leukemia, it is a myeloproliferative disease that originates in an abnormally potent bone marrow stem cells and is consistently associated with Philadelphia chromosome or the BCR-ABL fusion gene. This BCR-ABL fusion gene takes place between 9 and 22 chromosome. 9 and 22 chromosome. It was the first disorder for which leukemia term was used. It was first malignancy in which association with a recurrent cytogenetic abnormality was identified. And if you see Philadelphia chromosome, what happens? It is a reciprocal translocation between long arm of chromosome 22 and chromosome 9. So this is a translocation. Means what happened is there were two chromosomes. On these chromosome, on chromosome 22, BCR gene was there. On chromosome 22, BCR gene was there, and in chromosome, suppose this is chromosome 22, this is chromosome 9, BCR gene was there on chromosome 22, and ABL gene was there. Let me okay, so we have two chromosomes. One is chromosome 22, other is chromosome 9. On chromosome 22, we have BCR gene. On chromosome 22, we have which gene? A gene called the BCR gene. On chromosome 9, we had ABL gene. On chromosome, we have ABL. On chromosome 22, we have BCR. Well, then what happened? Fragment of chromosome 9, which carries the ABL gene. Joins with chromosome 22 at breakpoint cluster region BCR, forming a chimeric region. So see, chimeric gene. So here we were having the chromosome 22, and what happened? This ABL gene came and joined here. ABL gene came and joined here, and this became the BCR ABL gene, also called the and they produces a specific protein called P210. P210 specific protein, and the size of this weight is P210, okay, which has abnormally high tyrosine kinase activity. Increased tyrosine kinase promotes growth, and this causes proliferation of myeloid. This tyrosine kinase is very, very important, okay. Like this, it is there. It is called Philadelphia chromosome. Clinical stages and features. There is a chronic phase where it lasts for 2 to 7 years. Tiredness, weight loss, lethargy, splenomegaly, moderate, smooth, firm, and painless. Splenomegaly. Isolated phase, you will see the blast crisis leads to death within 1 to 2 months. And in this stage, CML turns into acute leukemia, either AML or ALL. Patients present with feature of pancytopenia, anemia, increased infectious purpura, and splenomegaly. See, these acute leukemias are such a leukemias in which you will lose the patient within 10 days, like that. You will see sometimes it is uh, Aleukemic leukemia. Aleukemic leukemia means in the blood reports everything is normal, but when it comes to the peripheral blood smear, the blast count is also normal, but in the bone marrow blast count is wrong and is increased. So then you will not order any bone marrow biopsy and all, and you will lose the patient. So it's very painful. Investigations: hemoglobin concentration reduced to about 10.5 gram per deciliter, total leukocyte count more than 1 lakh per cubic mm, and peripheral smear examination you have to do. Okay, so the RBC is normocytic normochromic anemia, marked in WBC marked increase in count, but here late myeloid series are predominant like myelocytes to mature neutrophils. Eosinophilia, basophilia is there, blast cells less than 20% in chronic phase, more than 20% in blast crisis. Platelet thrombocytosis, occasionally megakaryoblast and micro megakaryoblast will be same. So here, see here, this peripheral blood smear is called garden party appearance. You can find all forms. You can find the band form, you can find the eosinophil, you can find the RBC, myelocyte, neutrophil, metamyelocyte, everything you can find in the CML. It's like a party, garden party. So bone marrow examination is hypercellular bone marrow. Bone marrow is highly hypercellular. Hypercellular means what? Bone marrow is hypercellular. Myeloid hyperplasia with left shifted myelopoiesis, myeloid ratio increased 10 to 1 to 50 to 1. Hypercellular, in all cases you can write without any doubt, hypercellular bone marrow. Myeloid hyperplasia with left shifted myelopoiesis. Erythroid ratio is increased. Myeloid erythroid ratio. RBC is 1 whereas myeloid is 10. Like that. Megakaryocytes increase with frequent small immature forms. Bone marrow biopsy, paratrabecular cuff of immature neutrophils, 5 to 10 cells. Abundant segmented neutrophils are situated deep in the intratrabecular region of bone marrow. Number of erythroid precursors is reduced, but they show normoblastic erythropoiesis. Increased number of reticulin fibers, you can see cytochemical stains, leukocyte A, alkaline phosphatase, decreased staining in CML helps in distinguishing CML from leukemia reaction. Cytogenesis, fish technique is important for that, for the Philadelphia chromosome. Treatment is imatinib mesylate, which is a tyrosine kinase inhibitor and it's the drug of choice for the CML. Don't have to go for chemotherapy, this therapy, that therapy. Just take imatinib will inhibit the tyrosine kinase activity and the patient is back to normal. Okay, so in atypical CML, it is a CML in which there is the absence of Philadelphia chromosome. How will you diagnose? So it will become very difficult. Okay, because as soon as you see the Philadelphia chromosome with 210 kb, you will go for the CML. In ALL also, Philadelphia chromosome is there, but 190 kilodaltons. But here you will get 210 kilodaltons. And here in bone marrow picture, in peripheral blood smear, you have a garden party appearance where you will find the different cells. Okay, it will become very different cells. See, here you can find the RBC, eosinophils, band form, myelocyte, neutrophil, metamyelocyte, everything you can look at here. Okay, so so let's talk about chronic lymphocytic leukemia. It is a neoplasm of monomorphic small round B lymphocytes in the peripheral blood smear. Bone marrow lymph nodes admixed polymorphs and paraimmunoblasts, usually exceeding CD5, CD23. Clinical features: these are asymptomatic late stages present with easy fatigability, lymphadenopathy, and hepatosplenomegaly. So these are the right system of staging investigations. You can see here you will find the school appearance, school garden, not garden party appearance. Here you will find school appearance. Here all cells are similar. Smeared cells are there, normocytic, normochromic RBC, and small lymphocytes. Okay, bone marrow examination, increased number of mature lymphocytes are there, reduced myeloid as well as erythroid precursors. Markers of B cells are positive 19, 20, and surface immunoglobulins, IgM immunoglobulin, and co-expression of CD5, CD23. Cytogenetics rearrangement, IgG heavy and light chain genes, trisomy 12 and chromosome 13 Q abnormalities. Richter's syndrome in case of CLL, and isolated lymph node transform into aggressive large B cell lymphoma. Hairy cell leukemia picture you can see here. Morphology here, hair-like projections are there. This is the oval nucleus with a spongy chromatin. The chromatin is looking like a spongy with oval nucleus, typical oval nucleus, abundant bluish cytoplasm you can see. Leukemia reaction. What is a leukemia reaction? This is an important answer. Is an excessive leukocytic response by a normal bone marrow to a stimulus spilling over of immature cells into peripheral blood smear. Increase in total WBC count is to extent of 25,000 to 1 lakh. So lymphocytic response. Leukemia reaction is differentiated leukemia by bone marrow examination. If you see the bone marrow, you can see the normal bone marrow. And neutrophilic hemolytic crisis, hemorrhage, leukemia reaction and leukemia you can see. Here usually in leukemia reaction less than 1 lakh, here more than 1 lakh. Here proportion of immature cells is less. Here proportion of immature cells is more. Toxic granules in WBC present. Here toxic granules are absent. This is the main thing which differentiates. RBC count is normal, here it is decreased. Platelets normal, here it is decreased or increased because an alkaline phosphate score increase, here decrease. Infiltration of organs is absent because it is not a cancer, it is just a excessive, exaggerated response of your bone marrow because of the some toxic agent. Okay. So leukemia reaction is different from leukemia. Okay, causes of leukemia reaction is neutrophilic, hemolytic crisis, hemorrhage, severe bacterial infection, sepsis, okay, burns, eclampsia, vascular thrombosis, infection, meningitis, diphtheria, pneumonia. And infection, you can see the neutrophilia. So it's common that in infection, if you see the report of an MI patient, you will find out that he is suffering from infection. And his neutrophils is raised, he's having neutrophilia. One thing in infection is there or something, but you will find that there is an infection, neutrophilia is there. So lymphocytic is infectious mononucleosis, pertussis, tuberculosis, mumps, measles. Okay. So that's it for today's lecture. Thank you so much. Before ending, I just want to brush up the discussion what we did today. So normally, the blast cells are less than 5% of nucleated cells in the marrow. But in leukemia, which is a malignant condition, malignant disease of the bone marrow stem cells, here the abnormal cells are spread in the bone marrow and to the outside and deposit in the organs. So FAB criteria is more than 30%, but WHO criteria is more than 20% to declare it as a leukemia. So it is important to differentiate between lymphoblast and myeloblast because of difference in the treatment and the prognosis of the disease. So if you see in lymphoblast, it is generally a smaller cell, but myeloblast is a bigger cell with all rods in the cytoplasm. All rods are the red stained rods present in the cytoplasm. These red stain rods are nothing but the these are nothing but the endoplasmic reticulum. Okay, talking about the lymphoblast, the cytoplasm is scanty and the cell is generally small when compared to myeloblast. So the in myeloblast you can have acute myeloid leukemia or myeloblastic leukemia and or myelocytic leukemia, or you can have chronic myeloid leukemia. Talking about AML, so AML is acute myeloid leukemia, and this is seen between the age of 15 to 60 years, mostly in the adult, the old age people. You will find this in acute myeloid leukemia. You can appreciate that the myeloid blasts are increased. If you see the peripheral smear, the normal RBC is there, but the count of RBC and platelets are decreased. The WBC count is decreased, but the blasts are more. Okay, so the patient becomes more susceptible to infections. So ALL is the most common leukemia in children. Talking about ALL, it's most common in children and it's usually associated with lymphadenopathy. There are two types of ALL. a precursor B cell and precursor T cell based on the WHO classification. But based on the FAB classification, you have three: L1, L2, L3, ALL1, ALL2, ALL3. And talking about the WHO classification, you have some markers and defining it, like for the precursor B lymphocytes, you have 19, 10, 10, 19, 22, or 20, 10, 19, 20. So 10, 19, 20, these are the markers. And for the lymphoblast, T lymphoblast, you have CD 1, 2, 3, 5, 7. So these are basically single digits. If you talk about LL1, LL1 is a small regular, may have cleft. Nucleus is small regular, and the nuclear is clumped and fine, or nuclei is absent, and cytoplasm with no vacuoles. The vacuole is only present in AL3, and LL2 is present in the adolescents. Okay, this T1 is having poor prognosis, and it occurs in the adolescence age, in the teenagers. Okay, and here you can see the organ involvement like spleen, hepatic liver, meninges, testes. So males are more prone for this infection, and mostly they die. Talking about the diagrams, you'll see that only in LL3 cytoplasmic vacuoles are present. Clinical features are headache, bone pain, pancytopenia, anemia, fatigue, testicular swellings. Investigation, you'll find same pancytopenia with anemia and thrombocytopenia. And you'll see bone marrow examination from the lymphoblast comprised of more than 20% of cells. Cytochemistry will see the past positivity, and chromosomal analysis will find the Philadelphia, not in the ALL. Yes, in ALL you can find in the poor prognosis Philadelphia chromosome. So here you can find the two types of prognosis: good prognosis, bad prognosis. Good prognosis, you have the hyperdiploidy. For the good prognosis, hyperdiploidy. For poor prognosis, hypodiploidy. And poor prognosis, it will be seen in the ages less than 2 years of age, mostly in infants. In the infants less than 2 years of age, like in the children less than 2 years of age. And talking about the other than age, the chromosomes involved is hypoploidy. Philadelphia chromosome is mostly involved, and gene involved is MHA gene, MLA gene, MLL gene, which is bad prognosis. And the WBC count is more than 1 lakh, it means it's more severe. Uh, Talking about the other things, in good prognosis, you will see ages 2 to 10, between 2 to 10 years, that is 3, more than 2, 3, and hyperdiploidy 3. And you can see the chromosomes involved are 12 and 21, and the other chromosomes involved are, what are the other chromosomes involved? 8 and 20. No, no, no. It's not given here. It is not given, unfortunately, here. So, as I was telling, the other chromosomes involved are 4, 7, and 10. 4, 7, 10. 4, 7, 10. Okay, so this is about ALL. So get perfect in these answers. This can come as a short answers. And MCQ part also I told what can be possible. In AML, be careful about the in AML. It is minor leukemia. You have FAB and WHO classification. This is mostly asked. FAB classification, you have 7 times starting from the 0, which is undifferentiated AML. Then without maturation, with maturation, then promyelocytic, then myelocytic, then monocytic, myelomonocytic, then monocytic, then erythroid, then megakaryocytic at the end. Okay, here the lymphocytes are, here the myoblasts are the large in size. Nucleus is also large, and delicate chromatin can be seen. Nucleoli can be seen. Cytoplasm is abundant, basophilic, and contains plenty of granules. Here, OR are present. The special feature is OR and OR is stained with MPO and Sudan black. Um, OR are stained with MPO and the cell can be stained with Sudan black. Okay, the pass positivity is seen in ALL, not AML. ALL you can see the pass positivity like blocks can be seen. In AML, you will see a WHO classification, recurrent cytogenetic abnormalities, AML with translocation 8 and 21. 8 and 21 translocation you can see in recurrent and inversion of 16 and 15, 17 acute promyelocytic leukemia, which can cause DIC in future. AML with multilineage dysplasia, you can see AML with therapy related like alkylating agents and topoisomerase 2 inhibitor related. Okay, so these are for today's session. Thank you so much.